Good morning, sir. Dr. Vittal, sir. We'll start in, say, 5-7 minutes.
Yeah, very good morning, sir. Good morning, Dr. Vittal, sir. Are you able to listen my voice?
Yes, sir. Yes, sir.
Voice?
Hello.
Are you able to listen me?
Yes, sir.
Yeah, good morning,
Loud and
sir.
clear. Good morning, sir. So nice of you to join us, please.
Thanks, sir, and good morning, Vittal, sir.
Good morning.
How are you, sir?
Absolutely fine.
Thanks, and nice to see you again.
Likewise, the feelings are mutual.
Thank you, sir.
Yeah.
Students do not know, but they are awed by your presence, sir, because they don't know. You have
That's
been
always
working
good.
so.
As long as you do not know better, no expectations.
But sir, I definitely have a lot of expectations that will deal with this in detail so that my students have a lot to benefit.
Hopefully, sir. Let's hope for the best.
Right, sir.
Sir,
Just
I'll leave at 10:30 if you don't mind.
Yeah, sure. Yeah. Definitely. So nice of you to join, sir.
Because I had already fixed some commitments when you asked me day before yesterday.
Right, sir. No, thank you, sir. Thank you.
Since we are waiting, I will share some interesting anecdotes. My father, Professor Vittal, worked, his teacher, mentor was a person called Professor R. Sarachandra. That he was his assistant for more than 10 years. And Professor Sarachandra was known for his academic excellence. There's not a soul in our state who would not have heard of him. He passed away in 1989.
Oh.
He, what I would say, is a man known for his laconic wit and wisdom. So my father recollects so many anecdotes from him. So, I mean, he was so knowledgeable that when he goes as an examiner, my father was assistant. That time it was general surgery. So he will say, Vittal, these boys are not answering even simple questions, Vittal, he will say. My father will ask what? I just asked them elementary Krebs cycle. These fellows don't know. Imagine asking Krebs cycle in final MS.
Yeah. Agree.
So, and obviously standards were high. Very, very soft-spoken man. So his pass rate will not be great, and he will not, what shall I say? He will not worry about the results. He thinks if you ought to pass, you ought to pass. So he was a professor and head of the Department of Surgery. So one of these days, the exam took place. Obviously, the results were not very good. So what happened? As usual, the students at the end of the exam, when the results are not good, he is the internal examiner, HOD. They go and say, sir, what is this, sir? The results are not good. This is a massacre, sir, and all that. He will not talk much. He will talk only to selected people. And he used to love my father. He will not talk to others a lot. It'll just be monosyllables. They went on pestering. He had a black ambassador car. I remember when I was in, I had joined medical school, but I knew him as uncle. So students went on pestering. He got inside the car. Again, sir, what is this, sir? We are going on asking you. We think it is a massacre. He just closed the car door and said, I don't think it's a case of massacre, but a case of suicide. And he went away to the students.
Good morning, sir.
Anecdotes I know.
Good morning,
Pankaj bhai.
Sorry?
Good morning,
Dr.
sir.
Pankaj Modi say good morning, sir.
Hello, sir.
How are you?
I'm fine. I'm just trying to.
I was hearing it, yes.
If you want to hear, I'll tell you one more. At the time when he was about to retire, all the students asked them, because he was the first surgeon in the state, very famous man. Our Tamil Nadu ASI CME is named after him, Professor R. Sarachandra CME. So when he wanted to retire, the students went and asked, sir, we want you to extend, so you don't need to do anything. We'll take care of everything. You know, some of the students would have been influential with the government and all that. He didn't talk much. No, sir, just one signature, sir. We'll take care of the extension. He said, I don't want to flex to extend. Those were his words. That's all. I mean, you had such great personalities.
Yeah. I can understand him very well. I am on verge of retirement. Same problem. About to retire
So
now.
they'll do the same to you.
I don't know. Government never bans. It's the same thing. I don't want to flex.
That's what I mean. Just imagine the last one I will say.
Yeah.
He was the acting dean. I think we have to start. He was the acting dean. He was the HOD. The dean was on leave. He was an acting dean. And you know, in medical colleges those days, there'll be a lot of fun, frolic, some function in the medical grounds. So these medical students had some liquor and all that. Little bit of skirmishes. So the police wanted to reprimand. I think these are all told to me by my father. Reprimand and all that. So obviously, without the dean's permission, the police can't do anything. So the police came, he was the acting dean and said, sir, your students are drinking and all that, and he wanted to. He just kept quiet. Then he said, yeah, so what? They are drinking on medical grounds. The police laughed and went.
Okay, sir. Apurva.
Okay.
Yes, sir. Yes, sir.
Has joined
Yeah, Dr. Andhara has joined, sir. First of all, I am grateful and thankful to Dr. Krishna Vittal, sir, and Dr. Ritesh Agrawal for joining well before time, before we all were available. Thank you for giving your precious time on Sunday morning, sir. Andhara sahib, thank you for.
મારો અવાજ આવે છે?
હા સાહેબ, બિલકુલ આવે છે. Thank you, sir.
You are
Thank you.
audible, Hitesh.
Yes, sir. Dr. Dilip Choksi, sir, will also be joining us in a short while. Just basic rules. This is like any other PG exams. The student will be presenting a case of multinodular goiter on PPT. We will try and complete the history part first, followed by the examination and the
અપૂર્વભાઈ મારો અવાજ
treatment
આવે
part.
છે? I cannot listen to you.
Yes, sir. Yes, sir.
Your side, you might have muted something. You are audible very well.
So, if at all required, if you find that there is some flaw in the flow, you can stop the resident at any given time, but we'll try and complete the history first, and then we'll ask questions, and then followed by the examination and the treatment part.
I think you are joined by two devices. Yes, you are joined by two devices. Dilip bhai, good morning. Welcome.
Very good morning.
Andhara
Good morning,
sir,
everyone.
mute one of your instruments.
You are double joined. Apurva, can I interrupt?
Yes, sir.
No,
Yes,
no,
sir. Please,
actually,
please.
actually, I cannot listen to audio from your side, so I joined from mobile now.
Okay,
Right, sir. Right,
great,
sir.
Great. Okay,
You
sir.
are audible.
I'll try again.
Small request
I'll
to all
mute this and try
examiner and
again.
experts. Hitesh bhai,
Yes, sir.
Dilip bhai and all that this is the case of a probably solitary or multinodular goiter, but euthyroid. Because we will having a master class on a diffuse toxic goiter or a toxic goiter and solitary malignant nodule. So request to restrict the discussion to the euthyroid multinodular goiter. So students can have an insight in this. That's what I suggest. Yes, there can be some overlapping, but as far as possible, that's what my suggestion is.
Sure, sure.
Thank you very much. I think Apurva, we should start.
Yes, Dr. Vittal sir, Ritesh bhai, we are starting, right?
Please,
Sure.
please introduce Dr. Dilip bhai and others so people, residents.
Yes, sir.
will
Yes,
know.
sir.
Yeah.
Dr. Andhara sir is a professor at the Narendra Modi Medical College at Ahmedabad. Dr. Choksi sir is a professor at Parul Institute of Medical Sciences at Baroda. He previously was an HOD and professor at Government Medical College, Baroda. Dr. Vittal sir is an endocrine surgeon with Apollo Hospital, Chennai. He will be our subject expert. And Dr. Ritesh Agrawal sir, he is associated with the Bombay Hospital and Lilavati Hospital. And he is also a MCH endocrine surgeon with a vast experience. Both of them have a vast experience in thyroid surgeries and thyroid patients. I am Dr. Apurva Shah, doing my little bit under guidance of Dr. Pankaj Modi sir. I have never thanked him, but I am really thankful to him for inspiring me and being always there in such cases. Thank you, sir.
I would
Dr.
like to add
Pankaj Mohi
one
sir
thing.
is a professor.
Me and Dilip both joined government service on the same day, 19th August 1989.
Oh,
He was
Absolutely
retired
correct.
that day, so he retired early. I am following him. And
Right.
one more, I am also very interested in thyroid surgery. I do a lot of thyroid surgery, so I will be more than interested in discussion in this time. Please, shall
Yes.
we start, sir? Nikunj, share your slide and start.
Good morning, sir.
Good morning.
Sir, today I am presenting.
What happened?
Sorry, sir.
Is it an issue with myself or it's your problem?
No, sir. Slide is not changing, sir.
Okay.
So the history is 26-year-old female housewife from.
Ask somebody to help you out with the slide screen. Right? You continue with the case. અને જો પીજી માસ્ટર ક્લાસ પર અપલોડ કરેલું હોય તો એના પર શેર કરતો બી વાંધો નથી એના પર શેર કરતો.
Apurva, do you have his PPT? You can share then.
સાહેબ મારી પાસે આપણું લોકલ છે એટલે મેં રાખી નથી પણ એ લોકો પાસે હશે સાહેબ કારણ કે બધા છોકરા ખાસા એવા છોકરાઓ જોઈન કરેલું છે.
They all will have a technical, I think internet problem must be there.
You can read it, don't worry. You can probably just
continue.
read it.
Nikunj,
Yes.
you continue with the case. Ask somebody else to help you out and share yeah, okay, fine.
Fine, yes, okay. Make it full screen.
Yes.
Yes, great.
Sir, I am presenting a case of 26-year-old female housewife from Bhavnagar. Came to civil hospital Ahmedabad with chief complaint of swelling in front of neck since last 2 years. Patient was relatively asymptomatic before 2 years. Then she noticed swelling in front of neck, which is insidious in onset, initially of approximately 2 into 2 centimeter size, and gradually it has increased to present size over 2 years. It is not associated with pain, no history suggestive of hyperthyroidism or hypothyroidism, and it is not associated with dyspnea, dysphagia, and change of voice. Patient has a past history of tattooing over swelling done 1.5 years ago. There is no history of taking any medication or irradiation, or there is history of comorbidity or history of any surgery in past. In personal history, patient is vegetarian with adequate sleep and appetite, with normal bowel bladder habits. Patient has regular menstrual cycle and last menstrual date was 19th February. Patient has one full-term normal vaginal delivery with 3-year-old female child. There is no significant family history. Summary of my history is 26-year-old female from Bhavnagar came with a complaint of swelling in front of neck. For 2 years, which is insidious onset, gradually progressive and not associated with the pain or symptoms of hyperthyroidism or hypothyroidism, without any compressive symptoms or significant past family history.
Sir,
Past
anybody
history of
would like
family.
to ask any questions?
Yeah, yes,
So,
yes.
You can stop here.
Yes.
Yeah,
Okay, sir, please, it is open for discussion.
yeah. One, I like your short and sweet history rather than probably give a very, very laborious history of unrelated stuff. Your history has been short and precise. Just a couple of quick questions.
Yes.
I will not use female housewife. But I don't know about any male housewife. You said it's a female housewife. Probably say 26-year-old female homemaker, don't use the word. Next. You said about no history suggestive of hyper, that's good. You said no history suggestive of dysphagia, dyspnea and all that. A better terminology will be no history of pressure symptoms. That's what you want to know. Then what is the significance of tattooing over the swelling? Did the tattoo come first or the swelling came first? Did the patient have the tattoo after the swelling or the tattoo was present before the swelling?
Patient had swelling first. After noticing the swelling, after 6 months, patient had done tattoo over the swelling, sir.
Is it because he thought that is going to make him better? Some low, huh?
Yes, sir.
I think, sir, patient might have gone for some remedial expectation by getting that tattooing. Is it so?
Yes, sir.
Yes.
So that you should have specified that she went to some quacks for getting relief in this symptom by getting some tattooing, right?
Yeah. Okay. Why did you ask for history of irradiation in this patient?
Sir, radiation exposure can increase the chances of thyroid malignancy. That's why, sir.
Yeah, it is a history of irradiation to the head and neck in childhood. That is, okay.
Yes.
When you mean no
What radiation? What dose of radiation is important, doctor? Do you know?
No, sir. I do not know exactly.
Okay, so when you speak this history, you should keep in mind that you are going to be asked some question about this radiation. Is it low dose, regular dose, high dose? What radiation can lead to a malignancy of thyroid? Just
Sir,
keep it in mind.
long, low dose.
Low dose radiation. Okay.
Okay.
Carry on.
And remember, if they ask you what type of thyroid malignancy, it's papillary carcinoma. That is
Yes.
the one which is, yeah. Then you said something about family history. What is relevant? What sort of relevant family history do you expect, if at all, if it's positive?
Sir, thyroid disorders like some of the cancer have familial pattern. Along with that, Pendrin syndrome, it is also has familial relevance.
More importantly, many
Commoner.
people in the family can have goiter. That is more common. It may be just endemic also, but other people in the family can have goiters. Okay.
Yes.
But the history was precise. Over to my colleagues.
Yeah.
Yes.
And
One thing,
the iodine deficiency runs in family. Also keep that in mind.
yes, just from your history, you should have added that patient presenting with history of swelling in front of lower part of neck, because front of neck is a vast area, right?
Yes, sir.
And you should have also taken some history that this, what is the commonest neck swelling in our country?
Lymph node enlargements.
And what is her age? 26. So in this age group, what do you expect? Commonest cause of lymph node in neck is?
Tuberculous lymphadenitis.
No, reactive lymphadenitis. So you should have taken some short history regarding ruling out this illnesses. When you say that it is in lower part of front of neck, the probability of oropharyngeal and ear problems gets ruled out on its own, right? Then comes you should have mentioned the history, no history suggestive of tuberculosis, right? That is what can be added. Anybody else, sir?
Yeah, I want to ask certain questions.
Yes, sir.
Yes, sir.
Yeah, Nikunj, can
Yes,
you
sir.
go back to your first slide, please? So I will ask you point to point. Yeah. So she was a 26-year-old female from Bhavnagar, and she had a history of swelling in neck for past 2 years, you told. Next slide, please. Now, you told that swelling was insidious in onset and it gradually progressed. So what were the associated features for any swelling? You have to describe them. You had missed a lot of things. Apart from pain, you had not described what are the other features which are associated with any swelling which were present or absent in this case.
Sir, whether pain is present, sudden increase in size.
You have already told pain is not present. Any other feature you know which are present with other swellings?
Sir, sudden increase in size.
Okay.
Sir, with any other swelling present in the neck.
Yes. Or any other parts of the body?
Whether it is associated with fever.
Yes. Redness?
Yes, sir.
Any discharge? ulcer?
No, sir.
See, you should have to describe all these things because you are a third year student. You have to describe the history of swelling in detail. Examiner wants to know about the swellings. Unless your presentation is complete, they will stop you then and there only, and you will get stuck. They know
Yes,
you
sir.
know the diagnosis, but you have to present your history in the proper manner.
And don't presume that it is thyroid only.
Yes.
Yes, sir.
Okay. So apart from the associated features, you told there's no history suggestive of hyper or hypothyroidism. What are the features you have asked to the patient for hyper or hypothyroidism?
Sir, for hyperthyroidism, sir, I have asked whether patient has weight loss despite of increased appetite, whether patient is having diarrhea, insomnia, sleep disturbances, any anxiety, any palpitation, or experiencing of tachycardia, any weakness.
But that tachycardia is not a symptom.
Sorry, sir. Palpitation, sir.
Weakness and tremors.
Yes.
Mood swings. And what are the features of hypothyroidism?
Sir, hypothyroidism patient will be lethargic with cold intolerance, with generalized weakness, with constipation, and
Weight gain, menstrual
Weight gain,
irregularities.
sir.
She is young patient. Have
Weight
you asked
gain.
for fertility? Any
yes, sir.
miscarriages? Any
No
miscarriages?
miscarriages.
Abortions?
No, sir.
See, these are very important history when you are taking the history for thyroid. Functional disorders are very, very common in this age group of the patient, especially in the ladies.
Yes, sir.
Okay. In the next line, you have written dyspnea. Dyspnea is a technical term. It's a scientific term. In the history, you have to present the history in the language of the patient, whatever the patient has told. Patient does not know what the dyspnea is. So you should have told difficulty in breathing.
Yes, sir.
Not the dysphagia. You should have told difficulty in swallowing.
Yes, sir.
What kind of difficulty in swallowing is relevant and important for the thyroid swellings?
Sir, difficulty in swelling can be due to large goiter compressing the neck. It can be also due to retrosternal goiter compressing over the mediastinal structure. It can also be due to...
See, dysphagia is not because of compression in the neck and mediastinal structures. What is the precise thing what causes dysphagia?
Sir, due to infiltration of...
Not necessarily. It is over the compression on esophagus or pharynx, but those occurs in the very late stage because esophagus and pharynx are pliable structures. They can move on.
Yes.
So
Sir,
it occurs quite late. You have a short history of 2 years only, and the swelling is insidious in onset.
Sir, very large swelling, which is causing due to heaviness of swelling. It causes difficulty in swelling because of attachment to the constrictors.
Why dyspnea occurs in swelling?
Sorry, sir.
Why dyspnea? Why there is a
Sir,
difficulty in breathing?
dyspnea is due to large, long-standing thyroid swelling causes tracheomalacia.
Before tracheomalacia?
Sir, due to direct compression over the trachea and larynx.
Yes, trachea mainly.
Yes, sir.
Yes, sir. Do you know what is a scabbard trachea?
Yes, sir. Sir, scabbard trachea, after removing large thyroid due to tracheomalacia, the thyroid patency, the thyroid cartilage does not able to maintain its patency and causes...
No, better. Scabbard trachea is a different thing. You can identify it on X-rays or CT scans. So scabbard trachea is just like a म्यान of a तलवार. तलवार देखिए, sword देखिए.
Yes, sir.
Sword जिसमें रखी जाती है उसका स्ट्रक्चर देखा कि वो ऊपर की ओर थिक होता है, नीचे थिन होता है, टेपर हो जाता है. Trachea is also like that. So there is a deviation, angulation, and deviation.
Yes, sir.
Okay, so that is the scabbard trachea.
Nikunj,
Now,
just one, can I just interrupt Nikunj?
Yes.
Tracheomalacia is not, even though there's weakening, it doesn't manifest pre-operatively because your goiter is there giving support and splinting. So you should not say he's got difficulty in breathing due to tracheomalacia. Tracheomalacia will manifest only post-operatively. You should remember that.
Yes, sir.
Next
And
slide,
that is
please.
why what endotracheal tube do we use? Do you know? Regularly?
Sir, cuff endotracheal tube, sir. Plus,
And
Fully.
more than that? specific endotracheal tube for thyroid diseases?
Yes, sir. With metallic
Yes, armor tube.
Armor tube, flexometallic.
Armor.
flexometallic.
Okay, fine. Carry
Next
on.
slide, please.
So,
Next
so
slide.
why do one simple question, Nikunj, why which patients have tracheomalacia?
So patient is having when patient is having long-standing large thyroid
No,
swelling.
no. So large swelling, say goiter for 15 years, 20 years, he'll have, euthyroid patient will have tracheomalacia. Okay, so what is basic pathophysiology of tracheomalacia? Is it the sagging because of the heaviness of the thyroid or something else?
Due to pressure symptoms, there will be loss of.
No.
Sorry, sir, I don't know, sir.
As far as I know, it is basically usually you see in patients with hyperthyroidism, where hypervascularity of the trachea, hypervascularity of the thyroid causes runoff of the calcium from the trachea, and that causes the weakness in the trachea. That is tracheomalacia. So you see it mainly and only in cases where there is Graves' disease.
Yes, sir.
Otherwise, you don't see it routinely. Please go ahead. कोई पूछ लो, sorry.
Okay, carry on. What kind of medications you had specifically asked for the thyroid diseases?
Sir, I have asked whether patient has taken any medication for thyroid diseases like thyroxine or any anti-thyroid drugs, or patient has any other medication history, sir.
Nikunj, if
antithyroid
patient is
drugs?
very illiterate, how can you take history that patient is taking Eltroxin or antithyroid drugs? Patient is
Sir,
absolutely illiterate. He does
sir,
not know. Yes,
Sir,
how can
I would
you
ask.
Yes.
Sir, I would ask whether patient was taking empty stomach morning tablet or patient
Yes.
was taking TDS dose after meal.
Okay,
Any
okay.
medication.
One tablet or two types of tablet. Usually hyperthyroid will get beta blockers also, right?
Yeah.
You can also ask what is the bottle containing that, is it coming in bottle strips?
Number.
You can ask the cost. Can you know the dose of Eltroxin by asking the patient something, what dose she is taking, if she is taking at all? These are just general knowledge questions which you should be aware of being a resident. Can we know the dosage by asking an illiterate patient? He or she may not know what dose she is taking. There are, do you know what are the preparations available of thyroxine? Minimum?
Sir, 25 milligram.
12.5. So how can you know whether she is taking 50 or 100 or 88?
Sir,
88 is
sir, a milligram bolo.
Sorry.
Microgram,
sorry.
yes.
Microgram, sir. Sorry.
Yes. So you can know, just if you don't know, say don't know. There are color coding available in the form of color of tablets as well as the dose which is written on the bottle, right? These are international codes. Just like Foley's catheter, we have color coding. We have color coding for thyroxine tablet as well. Just remember, and next time when you go to ward, just see the tablet's color or bottle's strip, which is bottle, which is dose written 88 microgram is peach color like that, right? Okay, just
Yes,
to keep it in mind, all PGs. And it is given in Google also. You can check it.
yes.
Ritesh,
Carry
you
on.
are asking something? Dr. Ritesh?
Yeah,
No, I asked it. I think it is clear. I asked it and I answered also. Carry on.
Yeah. Yeah, Nikunj, carry on.
Yes.
Don't be fumble. You may
Okay,
not answer some questions. Keep the confidence as it is. Carry on. It
Sure,
happens.
yeah, Nikunj,
Just
you have
relax.
written that LMP was on 19th February. This is
Yes.
April. So she had been amenorrhea for more than 1 month. Have you done anything?
Sir, patient was admitted before, sir, 1 month, and sir, I have taken at that time. Sir, patient was then, sir, managed and discharged.
This is the problem. This is an unnecessary risk taking you people are taking in the exams. What is the need of giving exact date? LMP 15 days back, regular cycle. That's all. Come finish.
Yes, sir.
You could have modified it to 19th March then.
Of course, that's what I'm telling.
Continue.
What was the significant family history, as Dr. Sai Patel has asked? What was the significant family history you had taken apart from what he has told? What other significant family histories?
Sir, I have asked whether patient, a family member has similar swelling, whether any other related uh, thyroid swelling in family runs, or history of any other illnesses related to thyroid.
Anything specific? More important is the history of MEN syndromes, the multiple endocrine neoplasia type 1 and type 2 syndromes. So in those, you have a thyroid swelling, thyroid malignancies, plus
Yes, sir.
history of sudden cardiac deaths, sudden deaths because of adrenal pheochromocytomas which run in the MEN syndromes. So you have to ask about them.
Yes, sir.
Any history of renal stones because of concomitant hyperparathyroidism in MEN syndromes.
Yes, sir.
Okay, next.
Yes.
With your
Examination.
summary of history, what you interpret that what kind of swelling you are dealing with?
Sir, I am probably dealing with the thyroid swelling of benign nature, sir, with
Okay,
non-toxic,
continue.
without toxic features.
Continue.
Sir,
Non-toxic or is euthyroid? What do you think?
euthyroid, sir.
Nikunj, have you asked the question of any history of lump in abdomen in this patient?
Yes, sir.
So what is the reason why you will ask cases in which you suspect thyroid swelling, history of lump in abdomen?
Sir, in case of Graves' disease and Hashimoto thyroiditis, there can be hepatosplenomegaly. In case of malignant thyroid lesion, there can be secondaries in the abdomen.
Any other reason? Do you know some disease of the thyroid in which there may be associated malignancy, may be associated hepatosplenomegaly?
Yes, sir. In case of Mann syndrome, there can be associated pheochromo.
Good. Any other? Any other?
Like in Fab syndrome, there can be associated colon.
Lymphoma of the thyroid. Lymphoma is known to occur in the thyroid, and such patients may have associated hepatosplenomegaly. That's why you may ask history of lump in abdomen. Then you say something about patients swelling is painless. You said no,
Yes,
right?
sir.
No pain, history of pain.
Yes, sir.
Yeah. So what are the painful swelling of the thyroid? Can you narrate that?
Yes, sir. So painful swelling can be due to thyroiditis, which can be viral thyroiditis or Hashimoto thyroiditis. It can be also due to suppurative thyroiditis.
Okay. Any other
In case,
reason?
in case of Graves' disease, also sometimes patient complains of pain in the swellings.
In euthyroid patient, multinodular goiter, can he get the pain?
Sir,
Will he get
hemorrhage,
the pain? What can be the
hemorrhage,
reason?
sir, hemorrhage
Yes.
in underlying swelling,
Now tell me
or due
the
to infiltration of surrounding tissue in case of malignant conversation.
that can also cause pain. Now tell me the location of the pain. Can it be different from the region of the neck or the thyroid region at other parts of the body in a thyroid swelling?
Sorry, sir, I didn't.
Pain originating from the thyroid swelling, not occurring in the neck, but occurring in other parts of the body?
Yes, sir. Sir, due to
Example?
sir, stroma ovary and
No, leave trauma.
yes,
Except that. Trauma ovary. Okay, that leave that. Any other reason?
sir, due to associated hyperparathyroidism, there can be generalized bony pain in case of associated Mann syndrome, sir.
Okay. Any other place pain can occur?
Sir,
Can a patient of thyroid swelling can have pain in the ear?
yes, sir.
Ear. Yes. Tell me the reason why the patient of thyroid swelling can develop pain in the ear. There are different causes of pain in ear in which the pathology is not lying in the ear, but it is somewhere else.
Sir,
Among
referred
that
pain.
group, one of the reasons is a pathology of the thyroid. Tell me something about that.
Sir, it is due to referred pain, but sir, I do not know the cause exactly.
Referred pain, good. But from where the pain is referred to the ear?
Sir,
Record pain, you are saying that means there must be some neurological involvement leading to that pain in the ear, no? So
Yes.
where is the neurological involvement by malignancy of the thyroid which can give rise to pain in the ear?
Sir, due to, sir, I
Then
don't know exactly.
superior branch of the superior laryngeal nerve is involved by infiltration. It is a branch of the vagus. Vagus has got a posterior extra-auditory canal, posterior part blood neurological innervation. These infiltrations sometimes can give rise to pain in the ear also, especially on the posterior part of the extra-auditory canal. Right? Now, I would like to suggest you that you have mentioned the basic questions that is to be asked in the case of the swelling. You have made so many questions. And you cannot make your ODP and life so short like this. You have to narrate all the questions which are applicable in a basic swelling question. History of anorexia, weight loss, similar swelling elsewhere in the body, history of reduction in size of the swelling. All these are important and that you have narrated. Okay, you can go ahead now.
So there are both the things, Nikunj. If you see, both the things are good. If you have a short and sweet history, that is also good. In that case, if the examiner asks questions, you can always answer the question, or you can go. So both the things are, what way works in the exam is a different thing altogether, right? But it
Yes,
is a good thing that we have such an elaborate discussion. Continue. Go ahead.
yes, sir.
Pankaj bhai, तुम्हारा कहीं? Continue, Nikunj.
He is my student, so I don't need to opine anything. It's okay. He should be grilled like. Then he realizes that everything is not like that. But yes, the point is well taken that it is a balance which is required. Not a too long, not a too short. That's it.
Please mute these rains. Whoever that rains is, please mute him. Continue.
Yes, sir. Sir, I have examined my patient in adequate light and exposure. Patient is conscious, cooperative, and well-oriented to time place. Patient is well-built with thoroughly nourished, with normal temperature, with pulse rate of 93 BMI, with Karnofsky score of 100. There are no eye signs, no edema, clubbing, or lymphadenopathy.
I want to stop you, Nikunj, right here only.
Yes,
So you have told the pulse is 90 per minute.
yes, sir.
What are the kinds of pulses you know in thyroid diseases and how to examine those pulses?
Yes, sir. Sir, there can be, sir, there can be hyperdynamic pulse, collapsing pulse, or water hammer pulse. It is due to increase, it is hyperdynamic. It is due to hyperdynamic circulation, mainly seen in thyrotoxicosis. There could be pulsus paradoxus in case of large retrosternal goiters.
Another thing sir is asking is how do you examine it? So
That is very important. How to check for the collapsing pulse?
So, and you were saying something and then you stopped, I think, because you forgot. So, what exactly happens in collapsing pulse? Why it is called a collapsing pulse?
Due to wide pulse pressure, there will be sudden increase in a tension of the artery which is being examined, followed by that sudden drop causes impalpable arteries.
Good. So, how do last three? So, how do you palpate? Sir is asking.
So, by 3-finger method in a right radial artery, by proximal artery preventing the distal finger preventing the pulse coming from the ulnar artery from the branch, and proximal to assess the arterial stiffness.
What is the classical example of collapsing pulse? When somebody says collapsing pulse, what is the first diagnosis which comes to your mind?
Sir, due to hyperdynamic circulation secondary to anemia due to cirrhosis.
Collapsing pulse means aortic regurgitation. There are other causes as well. But you should have a holistic view. I know we are talking about a thyroid. Thyroid normally doesn't have a collapsing pulse. But yes, in hyperdynamic circulation you can have. But when the examiner collapsing pulse is characteristically seen in aortic regurgitation. Okay?
Yes, so one is collapsing pulse. What about arrhythmias? What about tachycardia, bradycardia?
Sir, in hyperthyroidism, there is a tachycardia with secondary thyrotoxicosis also known to produce irregular rhythm with missed beats with changes of cardiac failure.
So
Heart
what
failure.
kind of arrhythmias you know in cases of thyroid diseases? Name those. Just name those arrhythmias.
Sir, there's sinus tachycardia, which is more common in thyrotoxicosis, or in a case of myxedema, there can be bradycardia, sinus bradycardia. Along with in heart failure, there can be missed beats and heart blocks, sir.
Beta,
Nikunj,
just
sir is
name those
asking about
arrhythmias.
arrhythmias.
Just name the
Name the
arrhythmias.
arrhythmia.
Have you ever heard of PSVT, paroxysmal
Yes, sir.
supraventricular tachycardia?
So
Have you ever
paroxysmal,
heard,
yes, sir.
have you ever heard of atrial fibrillation, which is very common in thyrotoxicosis?
Yes, sir.
Okay. See, any kind of tachyarrhythmias can occur in thyrotoxicosis, atrial fibrillation, PSVT, and in very late stages, patient may go into VF, but extremely rare. Not common. Common is AF and PSVT and sinus tachycardias. And in myxedema, in this thing, hypothyroidism, you can get a sinus bradycardia.
Yes.
So here, actually, when you say I wanted to comment, I would not, when you are talking about the thyroid, I would not just stop with 90 per minute. I would have said 90 per minute, regular in rhythm, because it's
That's
very
why
important. My first question would have been, why have you not mentioned that? Especially for the thyroid, that is very important. Okay.
Yeah. Okay, so when you have describing the pulse in any case, you have to describe 90 per minute regular rhythm, normal volume. Character, there is no radial or radiofemoral delay. That is very important. Now coming to blood pressure. What kind of blood pressures you see in thyroid diseases?
Sir, in thyrotoxicosis, primary hyperthyroidism can cause hypertension, and in long-standing case of multinodular toxic goiter can cause heart failure.
But why heart failure in non-toxic multinodular goiter? There is no abnormality related to the functions.
No.
There is no abnormality related
No,
to heart. Then why
sir,
heart
he
failure?
said multinodular toxic goiter. He said.
Okay.
Ah.
So, but I'm asking simple question. What kind of
blood
pressure?
pressure, stick to blood pressure. Don't go for heart failure.
Yes, sir.
Just describe the blood pressure.
And very important, very simple answer. Don't try to be very smart.
Yes.
Sir, thyroid
Nikunj, one thing. Try to focus on the question and only on the questions. Na avde to na pad. You are falling in a trap. You are going to traps.
Let me tell you, for all PGs, the answers of questions which are not asked do not carry any credit. But if they are wrong, they do carry discredit. So be specific what is asked, answer that and that only. Otherwise, if you answer one more, you are missing a chance of asking a question by your examiner. So
the question is, what will be the change in blood pressure? And you are going to heart failure.
Yes.
Sir, if thyroid swelling is associated with the hypertension.
What is changes in blood pressure? Don't agarni vato band kar. Thyroid change. What are the changes you will find?
If you don't know, if you don't know, hypertension will you get? Systolic hypertension.
Yes, that is the only thing. Systolic hypertension. That sir has already told. Systolic hypertension. Diastolic hypertension. When you see the diastolic hypertension, Nikunj, when you see diastolic hypertension,
in old age cases due to
in thyroid diseases, diastolic hypertension. When you see, my question is very specific. In which thyroid disease you find diastolic hypertension?
No,
Nikunj,
sir,
if you don't know, you can say I don't know. It's a correct answer. Yes, that's good.
Hyper causes systolic hypertension, hypo causes diastolic hypertension commonly.
Yeah. And wide pulse pressure.
Yes.
That is the one thing actually you should have said first. You have already said about so much about hyperdynamic circulation that. But don't, what I like Hitesh, I am trying to tell all PGs, there are no smart answers.
Yes.
Don't try to be smart.
Yes.
Why did you raise the heart failure when the blood pressure was asked? They are very simple. Sir was asking what are the changes in blood pressure you will find in a case of thyroid disease. So if you know, then say wide pulse pressure, there can be a wide difference between leading to hyperdynamic circulation and systemic diastolic hypertension in specific case. Like that's it. Yes, sir. Please, sorry, continue.
No problem, sir. And what are the eye signs you checked for?
Sir, I have checked for whether there is any lead retraction or lead leg present or not, sir.
Anything else?
Whether exophthalmos is there or not, sir.
Anything else?
What things will give you a clue that you should check for eye signs if patient is hyperthyroid? There will be one inspectory findings. Tell me
Staring
that.
look of patient.
Before that, okay, that is one. That anything else?
So loss of
What-
wrinkling and anxiety face.
Just,
These are all
just
signs.
name those signs. Name those signs. What is the staring look known as? What is loss of wrinkling known as?
So
Name
loss
that
of
sign.
sir, staring look is known as a Stelbeck sign,
Okay.
and loss of wrinkling is known as Geoffroy's sign.
Okay. Very good. And what about this thing? Have you ever heard of word chemosis?
Yes, sir.
What is chemosis?
Sir, chemosis is a edema of conjunctiva.
Very good. So
If you see upper border of sclera, that will lead you to go for all these exams. Usually, upper part of sclera is not visible. Lower part you can visualize. Upper part of sclera to be visible, there has to be some disease, or you have to do some extra efforts to make it visible.
Yes.
Nikunj, can I ask a question?
Please.
So, will be the same eye signs you will see in primary actually we were not going to discuss, but the question is raised, let us discuss it. In a primary hyperthyroidism and in secondary or multinodular.
Sir, just I will quickly say, sir.
Yeah.
Normally, we associate eye signs only with primary hyperthyroidism, but there's no
Yes.
hard and fast rule. But generally, in primary hyperthyroidism only, you have this autoimmune, all these antibodies. Strictly
Yes.
speaking, in secondary, we won't. So let's not
You won't.
confuse for postgraduates.
Yes.
Eye signs,
Agree, sir.
primary.
And sympathetic overactivity. Yes,
Sir, I would
agree.
like to differ here. We do see in a secondary hyperthyroidism, but only as expert can write. That is, sympathetic overactivity will be there in both primary as well as secondary. Exophthalmos will be present only in a primary hyperthyroidism. In secondary, you will find only sympathetic overactivity, sometime lead leg in late spasm. But yes, sir is right. It is 99% it will be in a primary. So let us move forward.
okay. So Nikunj,
Yes.
what is the pathophysiology of these eye signs in Graves' disease? My question is very clear, specific. In Graves' disease, that is primary thyrotoxicosis, you find eye signs. What is the pathophysiology of these eye signs? Why these occur?
Yes, sir. In Graves' disease, due to presence of long-standing stimulating thyroid antibody, it causes deposition of glycosaminoglycans as well as round cells in a orbital area, causing exoptosis, exophthalmos. Along with that, due to long sympathetic overactivity, due to increased released thyroid hormone, can cause spasm of involuntary part of levator palpebrae superioris, and along with levator palpebrae superioris, sir.
Ritesh, unmute. Ritesh, please unmute.
So sorry. But what is the cause of palsy of lateral rectus in thyroid disease? It is not an involuntary, it is a voluntary muscle.
Long-standing cases causes of ophthalmoplegia, weakness of
Due to what thing? What happens inside the
Sir is
muscle?
asking why weakness? You are
Why
stating.
weakness? Why inside the muscle?
due to infiltration of muscle
Yes.
by fatty tissue
Yeah.
and glycosaminoglycans.
Yes, very good.
Very good. Yes. It is a
So carry
infiltration. Understand the question. Do not repeat yourself.
Carry
Yes.
on, please.
Okay, we should move forward because this will be a more discussion like. Yes.
Sir, in inspection, there is bilobe swelling present in the front of neck, more prominently on right side. I would like to describe right side first. There is approximately 6 into 5 centimeter size, which is size swelling, which is well defined, extending approximately 4 centimeter below the chin to 1 centimeter above the medial edge of clavicle, and lateral edge is behind sternocleidomastoid. There is also round tattoo mark present over prominent part of swelling. In the left side, there is approximately 3 into 3 centimeter size, well-defined swelling extending approximately 6 centimeter below chin to 1 centimeter above medial edge of the clavicle. Whole swelling moves up with the deglutition and lower margin of swelling is visible. There is no other swelling visible in the neck. There are no scars, no sinuses visible, vein or pulsations.
Sir, I feel that he should have written the whole swelling first, followed by right part of the swelling. See, if you consider it as a thyroid swelling, or if you consider it a single swelling, see, bilobe, but it's a single swelling. So you should take up the whole swelling as a whole first, followed by right side of the swelling, not right side. It's either right lobe of the thyroid or right side of the swelling and left side of the swelling. Rather than individualizing and then saying about the whole swelling. These are not two different swelling, the same swelling, right?
Yes, sir.
Can I just interrupt you here? What is the relevance of movement with swelling? Why is the emphasis on movement in swelling?
Sorry, sir.
What is the emphasis? Why do you say that the thyroid moves with, the swelling moves with the deglutition?
Sir, if swelling is moving with the deglutition, it is a telltale sign that it is of arising from the thyroid.
Why should a thyroid swelling move with deglutition?
The thyroid gland is enclosed by pretracheal fascia, which is attached to the thyroid cartilage in inferior cricothyroid muscle by Barry's ligament.
The pretracheal fascia is attached to the cricothyroid muscle, is it?
No, sir. Sir, the pretracheal fascia attaches to the Barry's ligament, which is a.
So the pretracheal fascia is different. Barry's ligament is different then.
No, sir. Sir, I mean to say, sir, there is a thyroid swelling which is enclosed by pretracheal fascia. There is condensation of pretracheal fascia which is attached to the larynx. And
what part of the larynx?
So cricoid cartilage, sir.
Cricoid cartilage, okay. So what happens?
And whole larynx, while doing deglutition, moves up due to constriction of inferior constrictor muscle. That causes a swelling which is arising from thyroid, moves up with the deglutition.
Okay. Why should larynx move upward? Yes, sir. One question.
More or less right. I'll just summarize and then my colleagues can see. The thyroid is, the first reason I would say is the thyroid is enclosed in the pretracheal fascia. Where is the pretracheal fascia attached? It is attached to the cricoid cartilage and the thyroid cartilage. When you swallow, as you rightly said, there's a constriction of the inferior constrictors. What are they? The thyropharynges and the cricopharynges. So what happens? The cartilage moves up, the thyroid and cricoid cartilage, and the fascia is attached to this cartilage. So everything within the pretracheal fascia moves up. That is one reason. Two, the posteromedial condensation of the pretracheal fascia is called the Barry's ligament or suspensory ligament of Barry. And where is it attached? The posterior aspect of the thyroid to the cricoid. So it is another reason. The third reason you can give is the isthmus of the thyroid is attached to the second, third, or probably fourth tracheal rings. So if it is closely approximated, when you swallow, the tracheal rings move and anything above it moves. So these are some reasons which you would give. But the most important is the enclosement of the pretracheal fascia. That is why anything which is enclosed in the pretracheal fascia will move up with deglutition, like your subion bursitis,
pretracheal fascia,
so on. If you understand this.
Nikunj, one question. Yes, why should trachea move with deglutition? It's a respiratory organ. Why should trachea move with deglutition?
Sir, during deglutition, closure of epiglottis is required to prevent aspiration of the...
Yes. Okay.
Sir, Vittal sir, I would like to add something more to that.
Please.
Pretracheal fascia is a unique fascia. All other fascia are attached everywhere. There is a, God has given that pretracheal fascia, it attach upper part with the cartilage, but it is a free hanging in mediastinum at the lower part. And
Yeah.
that's why it helps the movement with deglutition. That is also a reason that apparatus moves easily.
Yes.
Okay.
Ritesh,
Sir.
you have any questions?
No, sir.
Okay, continue.
For palpation, I have palpated swelling from front and behind of the patient. So, the normal temperature without any tenderness. Right side of the swelling is 6 into 5 centimeter, which is well defined with nodular surface with firm inconsistency. Upper margin of the swelling is 4 centimeter below the mandible and lower margin is 1 centimeter above the medial end of clavicle. Lateral margin is behind sternocleidomastoid.
Nikunj, I am interrupting, please.
Yes.
So, you have palpated the swelling from front and behind. And
Yes.
what about the inspection? Can you go back to the previous slide, please?
Yes.
See, just previous slide. Yeah, that's okay. Next, please. Sorry, I missed it. So there are no scarce sinuses, visible veins or pulsations. Thank you. Next, carry on.
Nikunj,
Yes, sir.
that is the one, I don't know whether the other examiner agree or not. You have said right side, left side. When you start palpation, you palpate first thyroid as a whole. So where is that? You say
That is
left
what
side.
that is why I told you.
Ah.
The same thing in inspection also.
Because it is a thyroid as a whole. Initially, you examine thyroid and then decide what are the nodules. This is actually I have checked it, but I also missed that. Please continue.
And not right side. It's a right lobe. See, basically, because it
Yes.
is.
You can say the
We
swelling
agree
is
that
in the
it is thyroid.
midline extending on both the sides. You can say
Yes,
like
sir.
that.
Yes, sir. Continue.
Sir, left lobe is 3 into 3 centimeter size, which is well defined with nodular surface with firm inconsistency. Upper margin of swelling is 6 centimeter below mandible and lower margin is 1 centimeter above the medial end of clavicle. Swelling moves up with the deglutition and lower margin is palpable. Swelling is freely mobile horizontally and not fixed to the skin. Trachea is in midline with normal carotid pulsation.
Nikunj, I differ here. Trachea will not be in the midline because there's a difference in the size of the swelling on both sides. One side it is 6 centimeters. 6 centimeters is quite a big size. It will cause deviation of trachea to the other side. So just clarify
Yes.
this point, whether the trachea is in midline or it is deviated to the left side.
Do you have the X-ray?
No, sir.
Okay.
Normally, when one of the swelling is significantly bigger than the other side, there's a tendency of the trachea to be pushed to the opposite side. So whenever you see a difference in the size, think twice before saying it's normal. A point which I would tend to agree with Dr. Ritesh.
Carry on.
Just one thing, if
And
somebody
here
has the
also,
X-ray,
what you are describing is the right side swelling measurement you have said. You describe the whole side swelling and then you describe the movement. You don't expect this swelling to be of 3 by 3 centimeter only. There is a big swelling in the neck, no? Extending on both the sides. Second thing, you have not mentioned any relation of the swelling to the sternocleidomastoid muscle. It is superficial to eat on palpation or deep to eat on palpation.
Sir, it is
And
deep.
you say it is a swelling is freely mobile in horizontal and not fixed to skin. So you are examining the patient with extension of the neck or flexion of the neck.
Sir, he has mentioned for right side, left side he forgot. Go back. Lateral
Now it
margin
is
is behind
systemic examination
sternocleidomastoid.
which is coming. That's why I am asking this.
Left side he has forgotten.
But can you come to the
Right.
next slide?
Okay, tell me whether swelling is superficial to sternomastoid. You say it is going out of the back side of the sternomastoid, it is touching that, or it is deep to sternomastoid muscle. What is the reason why you examine for this?
Sir, usually thyroid swelling in a posterior part of lobes.
So it is superficial to sternomastoid or deep to
No,
it?
sir, deep to sternocleidomastoid.
Okay, how will you check for that?
Sir, after fixing the head and ask patient to turn towards the opposite side of swelling against the resistance which is offered by the hand of mine over the chin. And I will look for the tautness of sternocleidomastoid which is being examined and look for the swelling, whether swelling becomes more prominent or less prominent. If it becomes more prominent, then it is above the sternocleidomastoid, and if it becomes less prominent, it is behind the sternocleidomastoid.
Can I just interrupt you over here? Your broad principles are right, but sometimes in a big swelling, you may not be able to elicit so easily. It is becoming less prominent. So a subtle ways, when you put your palm or whatever over the sternomastoid, if you can feel the muscle contracting, then perhaps the swelling is underneath. If you don't feel the muscle contracting, perhaps the swelling is superficial. This is in large swellings, you cannot make out it is above or below. This is some subtle tricks I'm telling you.
Yes, sir.
And what your palpation finding says that there is no swelling in between this right and left. So is it right on palpation, or there is a continuous swelling between right and left side, everything?
Sir, it is continuous swelling, sir.
Then you cannot describe it as right and left on palpation.
Sir,
Yes, sir.
already he is agreeing. Continue, we'll continue ahead. So thyroid is a single swelling. Always describe it as a single swelling, and then each lobe has to be described separately. Continue, please.
Yes, sir.
But the way you
Okay, now you
examine
see
is
carotid
good.
pulsation something now. Which carotid pulsation you are palpating? Where you are palpating?
Sir, I have palpated the common carotid pulsation. In
You are palpating common carotid pulsation. At what place you have palpated the pulsation?
sir, I have palpated lateral to the upper border of thyroid cartilage and medially to
So
the
where should be
sternocleidomastoid.
ideally, it should be palpable to note whether it is infiltrated or it is displaced.
Sorry, sir.
And please tell which carotid actually you are palpating.
Sir, common carotid I have palpated lateral to the thyroid cartilage, medial to the sternocleidomastoid, against the transverse process carotid tubercle, chesagnes tubercle, sir. Against.
What you are palpating is an external carotid artery, not the common carotid one.
Vittal sir was giving some points.
Can I tell something, please?
Yes, sir.
Yes,
Yeah.
yes, please.
See, what happens that common carotid artery at the level of thyroid cartilage is still a common carotid artery, and I agree with the student that he's able to palpate common carotid. It's very, very difficult to palpate external carotid artery alone, and that is present only in the upper part of the neck, not in the middle part. In that region, we usually palpate common carotid only, and that is at the level of C6 tubercle that he has very well rightly told, chesagnes tubercle. But in all thyroid swellings,
But at the upper level of the thyroid cartilage, you don't expect the carotid common carotid artery, sir.
So common carotid artery usually divides a very high up, not in the lower, but we usually see it daily, day in and day out. And what happens that he has to palpate the carotid artery below the swelling as well as the above swelling, so to find out whether there's a loss of pulsations above the swelling, whether there's any infiltration or any narrowing of the flow in carotid artery.
Yes,
so in
sir.
such large swellings, he has to palpate above the swelling also to find out any decrease in the flow, or which may point out towards any kind of infiltration or any other encasement also.
Yes, sir. What we are taught is that it is common carotid if that we
Yeah.
and
Can
we
I
are
just,
teaching the same
yeah.
to the students.
I tend to agree with the student and Dr. Ritesh. Just summarize about the common carotid. Number one, you palpate only the common carotid artery. Number two, you palpate it against the C6 tubercle. Remember, any artery you want to palpate, you'll only palpate against the bone. If it's the popliteal artery, it's the lower end of the femur. If any artery you always palpate. Similarly, you only palpate the common carotid artery. Number three, what is the importance? In large benign swellings, the artery will be displaced usually posteriorly and laterally. You will feel it, but it will be displaced. In malignancy, because of infiltration, you will not feel it. This is the clinical significance of carotid artery and the thyroid. And that sign is called Perry's sign. Just a short summary.
One more thing I like to ask student, not related to this subject, but how can you identify on table external carotid artery it is difficult many times to differentiate internal and external carotid artery, particularly when you are doing it in emergency for ligation in case of trauma or malignancy. Any idea, Nikunj?
Yes, sir. So now there is a fork, carotid fork, and through
No, no.
which
How do you, there are two arteries seen, external, internal. Which one is external? Which one is internal? Can you say,
the
tell me?
external
And how do-
artery, external carotid artery gives branch in the neck, while the
Exactly.
internal
Very good.
carotid
Very good.
artery does not give
Very
any
good.
branch.
Very
Very
good.
good. Very good.
In fact, the external artery is not as external as we think. It is actually a little bit deeper.
Exactly.
Ah.
Exactly. Yes, sir. That is the practical problem for a beginner.
Continue, Nikunj.
So, Nikunj,
You
sir
said-
was asking about Barry's sign. What is significance of that? Sir has very clearly said, what did you understand? Let me know.
Sir, Barry's sign is a absence of carotid pulsations.
That we know Barry's
Yes,
sign
sir.
significance. Don't repeat the things which has been told.
In case of benign swelling, the carotid pulsation moves more laterally and posteriorly, while in case of malignant thyroid lesion, it moves absence due to infiltration of carotid. There will be absence of pulsations, sir.
So, carotid sheath is made of
So carotid sheath is made of fascia. Carotid.
which fascia? Which fascia? It's the extension of pretracheal fascia again. So again, in a malignancy, chances of infiltration increases. So the principle here is that whether you are able to palpate the carotid at all or not. And secondly, if palpated, where it is palpated. So you have to say both of these things. Remember, this is very large thyroid swelling. Still, if you are able to palpate carotid, it is more likely to be confined benign. That is the principle of that. And that's why this all discussion, you should, whether you are able to palpate at normal site or lateral. And when you are not at all able to palpate, it goes more in favor of malignancy. But usually in today's scenario, the patients come long before that, and we have so much armamentary of the investigation that the importance of this clinical sign is now decreased. But remember, this is a principle is invasion and displacement.
I think it is decreased only because of our habits, sir, not because of investigations. We should not blame investigation.
I am reflecting the students' mentality.
Yes, yes. But that is our attitude. Every students and everybody's.
Continue,
Nikunj,
Nikunj.
carry on.
No
You
blue
go
on
further,
auscultation. What is the
Yes, sir.
what is the significance?
Sir, if patient is having hyperthyroidism, there can be bruit can be heard over superior pole of thyroid, sir.
Why superior pole or not the inferior pole?
Sir, in superior pole of thyroid, the superior thyroid artery comes in front and supplies there, sir.
It is not because it comes front. It is a direct continuation, a direct branch of the external carotid, and the volume of flow is more. So that is why you auscultate in the superior pole. Okay.
Yes.
How do you auscultate for a bruit in cases of hyperthyroidism? How do you auscultate by stethoscope? How?
Sir, by using a bell of the stethoscope over the superior palpable margin, I would hear for the bruise.
Good. You have written no cervical lymphadenopathy. Do you know the lymph node levels?
Yes, sir.
So what are the levels of lymph node in neck?
Sir, level 1 lymph node, level 1A is submental lymph node. Level 1B, it is a submandibular lymph node. Level 2 is a superior deep cervical lymph node. Level 3 is middle deep cervical lymph node. Level 4 is a lower deep cervical lymph node. Level 5 is posterior triangle lymph node. Level 6 is mediastinal lymph node.
But level 6 is paratracheal lymph node. Level 7 is mediastinal lymph nodes.
Sorry, sir.
Okay.
And you can qualify say superior mediastinal.
Yes. And the thing you have used the deep cervical rather than you can say upper jugular, mid jugular, and lower jugular. That is a better term.
Better one, yeah.
Okay, carry on.
In systemic examination, cardiovascular, central nervous system, respiratory, and abdominal examination is normal.
What did
Carry
you
on.
look for in cardiovascular? what did you look for? I know it's normal. What are the things you look for in cardiovascular?
Sir, I would look for any not rate of heart rate along with the murmurs, if any.
What type of murmurs do you expect in thyroid and cardiovascular system?
Sir, continuous machinery murmur due to
Why?
hyperdynamic circulation in primary thyroid toxicosis.
Yeah. And what are the other things you expect? Any added sounds? Or if the patient is in failure, as you said?
Yes, sir. There can be
Shifting of apex beat, enlargement of cardiac area.
yes, sir. Apex will
You
be
should be
shifted more
prepared,
later.
you know. I know it's normal, but if the examiner may point out and ask you, you know. Okay, carry on.
Any thrill?
So there is no thrill, sir.
Okay, carry on.
Okay. 26-year-old clinically euthyroid case summary of my patient is 26-year-old clinically euthyroid female patient with bilobe swelling 6 into 5 centimeter on right side and 3 into 3 centimeter in left side, which is well defined with nodular consistency, which is painless, which moves up with the deglutition without retrosternal extension or compression features, without any lymphadenopathy for last 2 years.
One more thing. Again, I would like to point one thing, that don't say a bilobe. Now, I mean, with so much of example, we are all discussing thyroid. You should always say it's a thyroid swelling with right side is this and left side is. Don't say, see, then you have to prove what it is then. And it's not a bilobe, it's a butterfly shape.
You can say
the middle portion you are forgetting. Yes, sorry, sir.
No. I agree with you. I would say 26. I would just say 26-year-old, whatever, presented with swelling in the lower front of the neck or the lower part of the front of the neck. I would say that rather than use bilobe swelling, if you want, you can just say with 2 nodules, one on the right and left, which is well defined and things like that. I will not use bilobe.
And why don't you put your clinical diagnosis?
So what is the provisional?
So my provisional diagnosis is non-toxic multinodular goiter.
Okay, what will you do now?
Sir, I would like to do...
Sir, Hitesh bhai, and for everybody,
yes, sir.
Because there is a lot of controversy sometimes in examiner side, whether the better word is a non-toxic or a euthyroid.
Sorry,
non-toxic or non-toxic word is better or euthyroid?
Both are correct. You satisfy the examiner. If you say is it non-toxic, you say no, multinodular goiter, euthyroid. If you say multinodular goiter, euthyroid, can you say in a better way? Non-toxic nodular, multinodular goiter. Both are the same.
And one or the other examiner will agree, other will defend you. Don't worry.
I always say, when it comes to the exam, knowledge takes a back seat. You should only pass the exam and please the examiner.
No. Yes.
So
what and many times examiners try to put their knowledge in front seat.
Yeah. So some toxic examiner will not agree to non-toxic, but
exactly.
But this is for a benefit of students, because they are many times confused. The word, because there are a lot of discussion. The word toxic, is it proper or? But it's all right. I absolutely agree. That's why I raised this point. You can use non-toxic word. You can use euthyroid. Excellent. So it is clear. Yes, sir. Please carry.
And only one more thing, improvisation at all the levels are important, Nikunj, because see what happens at times. This is thyroid case. If you have a case of portal hypertension, somebody is more interested in liver cirrhosis, he can always ask you about liver cirrhosis. So don't be adamant about what questions you are expecting.
Yes, sir.
It purely depends upon the examiner, what he is doing in his day-to-day practice. Somebody who is doing endoscopy will ask you more questions about endoscopy. Somebody will ask you about laparoscopy. They are all valid reasons for you. Valid questions. Like, please continue.
Okay, sir. So please now toward the investigation.
Yeah.
Dilip bhai.
And anything about provisional diagnosis? On their side, Dilip bhai? So only one provisional diagnosis, euthyroid multinodular goiter, right?
Yeah, clinically agreed.
With multinodular.
Sorry.
Sir.
તમારો અવાજ બ્રેક થયો
Go
ચોકસી.
ahead. What will
I think
Sir,
his
sir.
net is not working properly.
હા સાહેબનો
Well,
yes,
sir,
yes,
shall we
ચોકસી.
go for investigation now? Shall we proceed? Okay.
Yeah.
So now, Nikunj, what will you do now?
So first, I would like to do thyroid function test and ultrasonography of swelling, sir. Ultrasonography neck, sir.
So what do we expect?
Which thyroid function test will you advise?
Sir, I would advise thyroid stimulate TSH hormone level along with free T3 and free T4, sir.
Do you think all three are required? If only one is to be done, which will you do?
Sir, I would like to do thyroid stimulating hormone level assessment.
Yes. Why?
Because
Why
this
only
patient,
one? And in the no. Why if one is to be done, why only TSH?
TSH is a marker which well differentiate between hyperthyroidism and hypothyroidism, sir.
Before that levels of T3 and T4 fluctuate, usually the TSH increases in hypothyroidism and it decreases in hyperthyroidism. So, and there can be cases where T3, T4 are normal and TSH can be varied, that are called subclinical cases. And TSH only is good enough to rule out hypo and hyperthyroidism.
Yes,
Okay, carry on then.
sir, I would like to do ultrasonography neck of the patient, sir.
What are the things you expect in ultrasonography of thyroid?
Sir, I would look for the number of the lesion which appears, the consistency of lesion, the
You cannot see
echogenicity,
consistency. You cannot see consistency. What do you call it?
echogenicity.
Ultrasound, yes.
Yes.
Can I just interrupt you here?
Yes, sir.
You
Yes,
said
sir,
about
please.
the ultrasound. In the modern era nowadays,
Yes. Which
how is
ultrasound?
ultrasound generally interpreted? How are the findings given? If you do not know, say, I'll just say quickly because I'm going to leave shortly.
Yes, sir.
I don't know, sir.
Okay. First of all, what is the purpose of an ultrasound? The many different reasons. One, you will make out enlargement of the thyroid. Two, it can tell you whether it is a solid or a cystic. Three, it can tell you whether it's a diffusely enlarged or nodular goiter. Four, it can tell you whether it's a single nodule or multiple nodular. Five, it can tell you presence or absence of cervical lymph nodes. Six, because of that, it can pick up a suspicious nodule. Nowadays, when you send it to a good sonologist, the sonologist generally interpret the ultrasound. There are many ways, but what commonly used is the ACR thyroid reporting system. Are you aware of it?
Yes, sir.
What is the significance of the ACR thyroid system?
Sir, ACR thyroids classifies the thyroid lesion in a 5 types and help to differentiate between benign lesion, suspicious lesion, or probably malignant lesions.
Exactly. It is based on ultrasound. You want to determine the risk of malignancy in a particular nodule. So if you have 2 nodules, so each nodule you will have to do a thyroid staging. And what are the characteristics based on which the thyroid is staged? There are 5 things. Tell me that.
Sir, composition, whether
Yes.
it is solid, cystic, or spongiform, echogenic foci, whether microcalcification or macrocalcification is present.
Okay.
The shape of the swelling, whether it is taller than wider or wider than taller.
Yeah.
Then margins, whether it is irregular or well defined. And sir, echogenicity, sir.
Fantastic. You have done this well. I leave it to my colleagues. I know we have to elaborate more, but due to lack of time, I'm just leaving it to my colleagues.
Vascularity. Vascularity is very important in nodules.
Yeah. And they divided into 5, as you rightly said. Number 1 is benign. Number 2 is not suspicious. 3 is mild, moderate, and severe. So based on that, they will decide whether you want to do a FNAC or not. Okay. This is what I want you to understand. But at least I'm glad that you got a broad concept of it. Over to my colleagues.
Yeah.
Pankaj Modi, sir, can I leave?
Arey, sir, thank you for joining.
Thank you,
and giving your
sir.
input,
Thank you, sir. Thanks
Yeah,
a lot.
Thank you very much.
Ritesh, bye.
Thank you, sir.
Thanks a lot, sir.
Thank
Bye,
you.
sir.
Bye,
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 sir.
bye.
Pleasant having
Good day,
you.
sir.
It was
Thank you, sir.
Okay. Ritesh, sir, would you like to ask anything?
Yeah, just Nikunj, carry on. I will keep on asking.
Yes, sir. So ultrasonography, yes. What about lymph node?
Sir, there are no lymph nodes
No.
enlarged in.
Importance of ultrasonography for a lymph.
Yes,
What
sir.
is significance of that?
Sir, the ultrasonography helps to whether there is a lymph node enlargement is there or not, which level of lymph node is enlarged, whether there are suspicious features of malignancy which is noted in lymph node in ultrasonography.
What are the suspicious features of malignancy in a lymph node on sonography?
Sir, in ultrasonography, loss of fatty hilum with oval shape lymph node with
Not oval shape,
irregular.
beta. No, not oval shape. It is a globular shape. Oval shape is normal. Globular shape is
oval is
suspicious.
normal. It is reverse in thyroid nodule as versus lymph node.
Yes, sir.
Carry on.
With irregular margins
And
with increased vascularity.
and
one more important thing, very
Loss of fatty hilum.
microcalcifications.
Yes.
So for everyone's benefit, there's one very important point, and this is true till date in my practice, since I have operated more than 3,000 thyroids. Any lymph node which is cystic and present in lateral neck, in the presence of a thyroid nodule, is malignant unless
yes.
proven otherwise. This is
Yes.
a very important finding. Whatever the size of thyroid nodule is there, doesn't matter, even if it is 5 millimeters, 6 millimeters, very small. But if it is a cystic lymph node in the lateral neck, level 2, 3, 4, and 5, if it is a cystic lymph node, it has to be malignant and metastatic unless proven otherwise.
Yes, sir. And most of the times they are blackish in color because of some hemorrhage.
Yes, it's true. Carry on, Nikunj. Very good. Carry on.
Sir, ultrasonography suggestive of both lobes of thyroid and isthmus
That's
appears
okay.
enlarged.
We have read all these things. Next. So you have done sonography, you have done thyroid functions. What else you want to
Yes.
do
Now the next, what will you do?
Sir,
next?
I would like to do FNAC of this lesion, sir.
What kind of FNAC you want to do? You want to do FNAC
Sir,
by a sonologist or by a pathologist?
Sir, by sonologist, ultrasonography guided.
Why?
Sir, by ultrasonography guided FNAC, from suspicious lesion, I can get the aspiration and yield of the FNAC will be more.
Yes, very good. So do you know the FNAC grading system nowadays, which is prevalent for thyroid? What it is known as?
Sir, Bethesda grading system for FNAC
Very
of
good.
thyroid.
So how many grades are there in Bethesda?
Sir, there are 6 grades.
1 to 6.
Yes, sir.
Okay. So in your patient, the FNAC is follicular nodular disease, which is akin to nodular hyperplasia.
Yes, sir.
Now, what else you want to do?
Sir, I would, as it is a benign lesion.
How do you know it is a how do you know it is a benign lesion? See,
yes,
I'm not contradicting you, but there are certain points which are also pointing towards malignancy. This lady has a history of 2 years only. 2 years is very small for a thyroid swelling to become a 6 centimeter swelling. 6 centimeters is a huge size in 2 years. So do not neglect this thing. It is not a long history. It is a short history as compared to other swellings in other parts of the body. So you cannot say it is benign. What else now?
Sir, in FNAC or in whole history, sir?
All things. Now you have completed everything.
Yes,
anything else you want to tell, or it is completed now?
Sir, it is completed now, sir.
Good. So now let's discuss about the management. You told it is benign. Why you're telling it is benign, and what else you want to do before any other treatment?
Sir, in this case, there is no rapid increase in size of the swelling after swelling has appeared. It is not associated with pain or any compressive symptoms or other swelling, lymphadenopathy in a neck.
Beta, my question is clear. What you want to do now?
Sir, I would like to offer total thyroidectomy for this patient as a management, sir.
Why total thyroidectomy and why not subtotal thyroidectomy?
Is there any, sir, one thing, is there any role of a CT scan in such a patient?
Yes, I prefer to do CT scan in all such patients. There are certain reasons. Why, Nikunj? Tell. Why CT scan?
Sir, size of the swelling is very large,
And
there are suspicious of malignancy is also there, sir.
see, in your words, you were having benign. Then why suspicion? The role of CT scan is that because in such a nodules, there is a multinodular goiter. There are chances of detached thyroid nodules also present in the mediastinum. Also, there may be chances of certain lymph nodes which will not be shown on sonography. There may be paratracheal
Yes.
or mediastinal lymph nodes which will be evident only on CT scan, not on
And these
sonography.
are mainly involved. These are the mainly involved nodes in thyroid.
Yes. So these are the important
Any
things.
role
Plus,
of thyroglobulin in
Sir,
estimation?
Sir, in
Any role of thyroglobulin in
our practice, if it is a thyroid grade 2, if Bethesda is also 2, and USC doesn't show lymph node, is CT necessary?
yes, in my practice it is because
Hey,
many,
I'm not talking about it, because this is the question which will be asked in exam.
yeah,
And
that is the problem.
that is the problem. That's what we are
Yeah.
discussing. I understand it very well, but this is what we said. And it has been taught that if there are no evident lymph node on USG and clinically it is a benign disease, CT scan can be avoided.
I agree with you.
Yeah. So keep the resident, both are right way. So this
Yes.
is what I'm trying to tell you, that nobody is right and no one is wrong.
Agree,
Again,
agree,
you have to
fully
decide
agree.
on your feet what to do.
Fully
Right.
agree.
So
And
basically-
just for the sake of record, if this was my patient, I have not undergone CT scan. That's just
Okay, sir.
right.
But the thing is that if you have a CT scan available and the patient, at times, see, nowadays with educated patient, they would also want to go for a CT scan. So both ways are, again, it in the exam depends which way it goes. Continue.
Both are right. That's what I
Yes,
want to
both
tell.
are right. Yes, sir.
So Nikunj, you have told that you will do total thyroidectomy. Why not subtotal? It is a benign multinodular goiter. Why not subtotal?
Sir, the swelling is present on the both lobes of thyroid.
So bilateral subtotal. What is the problem?
So chances of recurrence of the nodule in a remaining left out thyroid is more, sir.
Very good. This is the precise reason that
Yes.
subtotal thyroidectomy is abandoned nowadays because she's quite young, 26, have a large lifespan, and after 15 or 20 years of the first surgery, there are high chances of recurrence in the leftover part of the thyroid. Very good. So, as Dr. Dilip sir has asked, are you aware of serum thyroglobulin or any role of serum thyroglobulin in this patient?
No, sir. I would not like to do serum thyroglobulin in these patients.
Justify your answer.
Sir, I am not suspecting any medullary thyroid cancer in this patient.
Beta, thyroglobulin is for papillary and follicular, not for medullary.
Not for medullary.
For what is the marker for medullary cancer?
Sorry, sir. Sorry, sir. Calcitonin.
Calcitonin. Do not confuse calcitonin with.
Sorry, sir.
No, it happens. No problem. No problem.
What is the
It's
role
okay.
of thyroglobulin and calcitonin in this patient? Will you like to do or will you not like to do?
Sir, I would not like to do thyroglobulin. Sir, thyroglobulin only has a role in post-operative patient for follow-up, for recurrence or the remaining tissue, whether it is there or not, for recurrence or if any other metastatic lesion which is developing.
Very good. Very good. And what about calcitonin? Will you like to do it in this patient or not?
No, sir. I would not like to do it, sir.
Justify your answer.
Sir, I am not suspecting a lesion arising from the medullary thyroid carcinoma in this patient, sir.
See, Nikunj, what happens that according to the guidelines, the most common prevalent guidelines are American Thyroid Association guidelines for thyroid nodules. For calcitonin in multinodular goiter or in single thyroid nodule, they say that we cannot recommend. It is up to the examiner or up to the doctor, clinician, whether they want to do calcitonin or not. So it is not a hard thing, that hard and fast that you cannot do. You can do calcitonin, just doing no harm. If available, you can do. If not available, you can omit it.
Yes, sir.
Okay. What next? Apart from tumor markers, any other special blood test you would like to do? Any common blood test you would like to do in this patient? As you are going to offer the patient thyroid surgery?
Yes, sir.
Any common
Total
blood test?
hemoglobin estimation.
Any specific common blood test which is relevant for thyroid surgery?
total thyroidectomy શું થાય?
Calcium, sir.
Yes, very good. Why calcium?
Sir, calcium to sir know the parathyroid function.
Yes. So what happens during thyroid surgery to parathyroids?
Yes, sir. In thyroid surgery, there can be there is chance of injury as well as removal of parathyroid gland or temporary uh, injury, vascular insult to the parathyroid, sir. So that's why, sir.
What happens?
Sir, there can be temporary hypoparathyroidism post thyroidectomy, or there can be persistent hypoparathyroidism post thyroidectomy, sir.
So how it manifests? What symptoms patient present with?
Patient usually complains about the perioral numbness with tingling and numbness sensation over both limbs. Sometimes there can be spasm of upper limb and low limb. In a very severe form, it can also manifest as a tetany, sir.
Very good. So one thing is calcium, one thing is thyroglobulin and calcitonin, and you have done sonography and you have done FNAC and thyroid functions. Now you are prepared for thyroid surgery. So you have offered total thyroidectomy. What will you tell your anesthetist?
Sir, just one small thing.
Yeah, please.
Apart from all these investigation, any one particular examination you would like to do before going for surgery?
Yes, sir. Indirect laryngoscopy, sir.
Fine.
Very good. So,
Sir, for our students, in exam, many examiners believe that IDL should be included in your clinical examination.
yeah,
So just
agree.
keep this thing in your mind. Some places it is available, some places it is not available. So
Yeah,
actually, it is not an investigation, it's a part of clinical examination. Keep that thing in your mind.
Yes, sir.
So, okay, Nikunj, the patient has been taken on operation table. So what will you tell your anesthetist?
Sir, I would ask my anesthetic to while doing intubation, look for the vocal cords along with if swelling is large, I would ask for ferrexometallic tube placement, and sir, for position, sir.
What is the role of inserting nasogastric tube in your thyroid surgery? Right tube. Any role?
No, sir.
Okay. I prefer, and it helps during surgery to identify esophagus. It really helps. So I would like to request that all surgeons should prefer to use rice tube. It really helps.
Okay. But he will not know because we never put it.
Yeah,
Yes.
I agree, sir. No problem.
Okay, fine.
So
Doesn't matter, Nikunj, but yeah, good point you should remember.
Yes,
particularly when the sir is talking about it is what we operate usually is a benign disease most of the time. So they are free, confined in the capsule, identifying the structure is easier. But when
Yes,
you are
sir.
operating large malignant cases, this will definitely help. In that context, you should understand. Sir, am I right?
Yes, sir.
Yeah, I agree, sir.
Even in benign, there are almost 360-degree encashment of trachea and esophagus, pre-tracheal space, pre-vertebral space it reaches. So it is better to insert rice tube.
Okay.
The
So
problem.
Nikunj, describe the steps of thyroid surgery.
Sir, for position, I would starting from position, from rose position, after painting dressing, Kocher's thyroidectomy incision.
What is the coccus thyroidectomy incision? Describe it.
Sir, it is a horizontal incision, two
It is
finger
not.
width.
It is not horizontal. It is a curvilinear.
Yes, sir. Sorry, sir.
Curvilinear incision in the lower skin crease,
Or
which is known as a low
concave
column
upward. The word is a concave upward.
Yes.
Two finger
Next.
width above the sternal knot.
No two finger width. A finger is a very large thing.
It depends
This
whose
is
finger.
very problematic. Always saying in a two finger width. Two finger becomes 4-5 centimeters. Just think it over.
2 centimeters.
You have given an incision. What next?
Sir, I would subplatismal plane should be created superiorly above the thyroid cartilage, upper pole of thyroid cartilage, inferiorly above the to the suprasternal knot, laterally
The incision, lateral extra of the incision.
to the medial border of sternocleidomastoid.
No, beyond that, medial border is very
lateral border. You
has
always
to be-
expose sternocleidomastoid.
Yes, till the lateral border, because if you are exposing only the medial border, you will not be able to take the thyroid out.
Yes.
Okay. After that,
Subplatismal plane
you have already
created.
raised.
You already said that.
Sir, I would after I would lift the sternocleidomastoid and the lateral border of the thyroid will be dissected and from the carotid sheath.
You have only dissected you have only mobilized the sternocleidomastoid.
What about
Still,
the
strap muscles.
straps?
Yes, sir.
Strap muscle.
What
Sir,
about the
then
straps?
I would I would mobilize retract the strap muscle laterally by opening the
No, but where
investing
do you
layer
open? Where do you open the strap muscles?
in midline, sir. In investing
How do
layer of,
you how do you define the midline?
sir, it will be between the two anterior jugular veins.
Any other method? Any other method?
What do you routinely see?
What do
Especially
you,
in
what
such
do
a
you
patient?
normally see in midline? Palpate
What is
it and then say additional. Anterior jugular vein is additional.
What is the hard thing you feel in the midline? Hard thing.
Beta, notch, upper
Yes,
midline notch you
Superficial
feel.
notch.
Adam's apple. From that you start it. Anterior jugular is a subsidiary of that additional part.
Okay. So,
Hmm.
what are the strap muscles you know? What are the names of strap muscles which come in thyroid surgery?
there is a sternohyoid, sternothyroid, and
Huh?
superior belly of omohyoid.
Very good. And these are supplied by which nerve? Does that nerve come into the picture during thyroid surgery?
Sir,
Yeah.
ansa cervicalis. Sir.
Very good. It is ansa cervicalis. Okay. So you have opened the midline. What next?
So how do you know that you have opened the midline adequately? I mean, sorry,
Yeah.
the plane is right. How do you know that you are behind the strap muscles and you are not in the thyroid or in the muscle?
Sir, it will be above the false capsule of thyroid plane of.
So how do you identify? You see the vessels. You don't open the capsule, right? You
Yes,
see the
sir.
vessels. Okay. Sir Pushata. So you have defined the midline. Now what do you do?
See what happens, Nikunj. My direct question. Will you divide the strap muscles in this patient or not? Yes or no?
Yes, sir. Sir, I would divide the strap muscle in this patient.
Why?
Sir, swelling is very large.
Very good. That's the only thing. That's all. Sufficient.
Nikunj, you can close the slide sharing. You can come as a gallery. Everybody can
Yeah, please.
ask.
Stop screen sharing.
Yes, sir.
Yeah. And go to gallery mode.
Yeah.
Yes, sir.
So you have divided the strap muscles. Will you divide the strap muscles on both sides or one side?
Sir, in this patient only on right side, sir.
Why not on left side?
Sir, the swelling.
See, in this patient, if you have to divide the strap muscles, inadvertently you have to divide the left side also, especially the sternocleidomastoid, because it will be lying over the right side only.
Yes, sir.
Okay. Chalo. So you have divided the strap muscles. You have exposed the thyroid. What next?
Sir, I would begin dissection at the upper pole of the thyroid and identify the superior thyroid vessel, and will ligate close to the thyroid gland by identifying external branch of superior laryngeal nerve as well as superior parathyroids.
Okay. How will you ligate it? Which suture you will use?
So Vicryl 20, sir.
Why not Vicryl 30?
Because I always use Vicryl 20.
30, it's better because it's thinner, sir. Okay, that's okay. Granted. What
Sir,
next?
there was a, sorry, I had an important phone from resident.
Yeah.
There was some discussion about the cutting of the strap muscle.
Yeah.
We did not cut strap muscle in here, and I almost always do not cut. What I cut is a partial, only cut sternothyroid.
Yes, sir.
And do not cut this, just for the knowledge of the student, because it is a sternothyroid which covers the upper pole of thyroid and keeps it hidden from that. So if you cut even only sternothyroid, that should be all right in most of the cases, unless the lump or toxic or very large tumor. In malignancy, it's a different thing. Did you ask, sir, why it was cut in upper part?
Yeah, Nikunj, tell
Why it
upper
is cut
part
near
only?
as high as possible?
Why?
So
The
because
question
of
should have been,
insertion
where do
of
you cut, sir?
the insertion of the sternothyroid
Question should have
is
been, where do you cut?
sir, insertion of sternothyroid is at a hyoid bone.
No.
Prabhu,
No, why
don't
cut the-
repeat nonsense things. Nikunj, what was the question? Why it is cut at higher end? તને insertion થોડું પૂછ્યું છે?
સાહેબ,
You
એવું
can
નહીં
cut in
પૂછ્યું
lower
કે
part, you
now-
can cut in
now
upper
supply
part. Why
side
do you
will
cut
Why
in
it is
upper
cut in
part?
upper part?
You have already
Exposure
answered it. You have already answered it partially.
superior
yes.
thyroid
No,
superior
नहीं,
pole
नहीं.
is
no.
What about
Now
the now
supply.
supply? साहेब, मैं पूछूं
Now
तो करो
supply.
कि now supply देखे कि नहीं?
बेटा मैंने नर्व
Sir
सप्लाई
has already asked the question.
He has
Let
already
me ask
asked
a
you the same
different way.
question.
What is
I
the
think we thought he
literal
knows
meaning of
by
ANSA? What is
he said
literal
answer, so
meaning
we
of
knew we
ANSA?
thought he knows the answer. We thought he knows the answer, so we didn't ask. It
Ah.
comes from below.
What is ANSA means reversing. So ANSA cervicalis enter and supply going below and upward. So blood supply and nerve supply enter from lower down. So you can cut strap muscle as upper part. I think I must have told them 10 times, but it's okay. Part and
That's
parcel
why
of
we
it.
have it, sir.
It's common with
Yeah.
the students, sir.
Yeah.
Yes,
Continue,
it's
continue.
okay. But
So
just for
after
the others'
identifying-
benefit, I repeated it. Yes.
So after identifying after doing the superior pole dissection, you have saved the external bunch of superior laryngeal nerve. You have saved the superior parathyroid. What next? Now what will you do?
sir,
Nikunj, did
I
you
would-
mention middle thyroid vein? Nikunj, did you
He
mention
did
middle thyroid vein?
not.
no sir.
He did not.
He forgot.
When do you tackle it?
Where
Sir,
do you tackle it and when do you tackle it?
It is
Where and
first
when?
it is a first thyroid vein to be ligated after
Why?
exposing
Why?
the thyroid.
Why?
Sir, because it is a thyroid direct tributary of inferior thyroid vein, and
Yes,
if
and-
any injury
and-
happens to it, it will
And
be
it is very short. If it bleeds, practically you have to repair internal jugular vein.
Yes.
yes.
That is the bad part. And you can say, what is the good news about middle thyroid vein?
It's
That is bad
Nowadays,
news.
it is,
it's
nowadays
a
it is
myth.
not been.
Why he has not
It's-
mentioned it?
So because it is not present in all population, in
Yes.
prevalence is 30% only.
50,
It is not
That
present
is why you
always.
have to be
And
more
second
careful.
thing,
You always presume that it will not be present, and it will be present. Many times it is present only on one side. This is what I have observed. So, so don't presume that it is not present on the right side. It will not be present on left side. Right? There are no rules for
Sir,
middle thyroid vein.
Sir,
one more
before we
point.
go, sir,
Apurva, let me complete.
sorry.
One more point here is that middle thyroid is not always middle.
Yes, sir.
Many a time enter the lower part and it is mistaken as an inferior thyroid vein. But
Yes.
you should always assume it is present and always look for it because it is a short and enter the internal jugular vein, not inferior thyroid vein. That's why it is likely to be in there. Yes, please, Apurva.
Sir, but one more thing just for the students regarding the endotracheal tubes with nerve stimulators. Sir, Dr. Ritesh, you use it routinely or what is your take on
I
those?
don't need. I have the facility of this thing, neuromonitoring tubes, but I
Okay.
don't use it regularly. I have the facility,
Right.
but I don't need it because I have always identified the RLN easily, so I don't need it actually.
We also don't
I give
do it,
one
but there
example.
is-
I give one example. If you know the road where to go, you don't use GPS. Otherwise, that will create trouble.
Very well
Apart
said,
from
very
that,
well said.
Sir.
it is a more important in a malignant cases
Yes.
and in a recurrent cases.
Recurrent
So
cases.
yes, in a routine cases, we also don't use it. But for a future, for the students, there is going to be some, you should know what is that. That's it. Yes.
That is why I said that if you know the route, you don't use it. If you don't know where I'm going, you can use that GPS.
Continue.
Yes.
Yeah. So after doing the superior
Sir.
pole dissection, what will you do?
Sir, I would like to do inferior pole dissection, and I would tie the inferior thyroid artery as close to the thyroid gland by saving the parathyroid and recurrent laryngeal nerve, which is identified in the tracheoesophageal groove.
Nikunj, the better term is you will not ligate the inferior thyroid artery. You will ligate the branch of the inferior thyroid artery which is entering the thyroid. You will never
Yes.
ligate the main
Yes,
trunk of inferior
He
thyroid
has
artery.
seen 100 times the
Why?
branches are ligated, but still he is going for that. When did we
That's fine,
ligate
sir.
the
That's
inferior
fine.
thyroid artery?
That's fine, sir. That happens.
no, sir.
That's fine.
Branches of
That's fine.
inferior
Because
It happens.
it is why it is
No,
important. Why it is important, Nikunj?
So because inferior thyroid artery also supplies parathyroid,
Yeah.
Very
First,
good.
it supplies parathyroid. Then
then
the
it
distal branches supply.
inferior pole of thyroid and isthmus.
Yes. Okay,
What is
granted.
the common relationship of recurrent laryngeal nerve in terms of inferior thyroid artery?
Sir, recurrent laryngeal nerve lies posterior to the inferior thyroid artery.
Usually, not always.
Usually,
Yes,
not always.
Okay. So just describe the course of right and left recurrent laryngeal nerve.
sir. Right recurrent laryngeal nerve courses through it winds around the right subclavian artery, and then behind from right carotid sheath posteriorly to the right carotid sheath and right inferior thyroid artery. It comes in a tracheoesophageal groove, and it goes into the thyroid cartilage, sir. At
It goes
at
into
the
thyroid cartilage or somewhere else. It goes
Thi-
behind the inferior constrictor. This is the last point where we can see the recurrent laryngeal nerve. Inside it, it disappears inside the laryngeal framework.
yes,
And it is
And,
the
Supplies
most
all the
common site
extrinsic
of
muscles.
injury. Many a times it is most common site of injury. You know that if you have dissected in tracheoesophageal groove and you are very casual in dissecting the
Yes.
isthmus and upper pole from trachea, and there it is likely to be damaged.
Yes, sir. Fully agree.
sir, on left side, it is going wind around the arch of aorta, ductus arteriosus, and then come behind the left carotid sheath and behind the left inferior thyroid artery, then into a tracheoesophageal groove and into the inferior constrictor.
Okay. Very good. So, is it necessary to see recurrent laryngeal nerve in all surgery, or we should avoid looking for the recurrent laryngeal nerve during surgery?
Sir, it is mandatory to see the recurrent laryngeal nerve in order to safeguard it, sir.
Okay. So you have saved the recurrent laryngeal nerve, you have saved the superior and inferior parathyroid, you have cut the thyroid branch of the inferior thyroid artery. What next?
Sir, I would separate the thyroid gland from the Barry's ligament.
What about the capsule? You take the capsule along with thyroid, or you just leave the capsule behind and take the gland out?
Sir, take the capsule in case of benign lesions.
How do you know it is a...
Sorry, sir, would take capsule, sir.
Okay, good. What is the difference between capsular dissection of thyroid versus prostate?
Sir, in case
Yes.
of thyroid disease, thyroid, the true capsule is formed by the thyroid parenchyma, while the false capsule is formed by the pretracheal fascia, and vessels are lies beyond the false fascia, pretracheal fascia.
Between.
Yes,
Between
sir.
true and false.
Yes, sir. And in prostate, it is lies in the prostatic stroma, which is behind the true capsule, sir.
Okay.
What is
So that
what is capsule of prostate? If you are dealing with open surgery of benign
Yes, sir.
prostatectomy, what are the true and false capsules? The false
Sir, I
capsule
don't know,
is
sir.
false capsule is formed by the compressed zone of carcinomatous zone of prostate itself, right? It is not the capsule, it is the prostatic carcinomatous zone tissue, whereas you remove only the adenomatous zone. That is why even after doing open Millins or Freer's prostatectomy, patient is very much likely to get carcinoma prostate, and the vessels lie outside the false capsule, that is the compressed zone. And this figure is very nicely given in Ferguson book of textbook of operative surgery. I very well remember because I was very confused in my third MBBS, and I went to library, and since then it is very clear. So you read it, right?
Yes, sir.
And you remove only, that is why when you do Millins prostatectomy, you incise the false capsule, that is the tissue of compressed zone of carcinomatous zone of prostate itself. you remove the gland, and then you close the capsule, that is prostatic tissue itself, which is compressed by the adenomatous zone, right?
Yes, sir.
Okay. So you have removed the thyroid. Do you know what you have taken the thyroid right lobe, you have taken the left lobe. What are the other things you will remove during this surgery?
Particularly this patient.
This
Apart
patient,
from
right
right
lobe,
and left.
right lobe and left lobe have been taken out. What else?
Along with isthmus.
That isthmus given. What else? Is there any other lobe of thyroid you know? Any other lobe?
Yes, sir. Pyramidal lobe.
Very good.
Yes, sir.
So you will take the pyramidal lobe also with this,
Yes,
and
sir.
look for any detached thyroid nodules. If they are present, you have to remove them also during the same surgery.
Yes, sir.
Now, how will you close the wound?
Sir,
Sorry, and any other lobe you know? Which is
Zuckerkandal.
lobe of Zuckerkandal. Actually, nothing but extension of a lobe, but keep that thing in mind if somebody asks you. Yes, please continue.
How will you close the wound?
Sir, I would close the wound with the approximating the strap muscle in a midline, and by simple
Would you
interrupted
drain the
sutures,
wound?
followed by
Would you
that.
drain the would you
Sir,
drain the wound? See, before closure comes a drain, right? So
yes, sir.
sir is asking how would you close it? So
Sir,
You can
if
say what you
there is,
practice. You can say whatever is practiced in your unit or your hospital. Don't
sir,
hesitate.
we usually don't keep a drain, sir. If there is a
That's fine.
large plane of dissection or suspected bleeding, if there is a
In a
large plane of
suspected
dissection,
bleeding, you control it. In a
sorry, sir.
suspected bleeding, you control it.
In
Right?
case of
Putting it to a drain or not is a subjective surgeon's choice. Right?
yes, sir.
If there is a bleeding, you don't put a drain.
Hitesh, I would tell you
Yes,
one
sir.
important, because in my unit we do a lot of thyroids, at least 10, 15
Yes, sir.
thyroids
Even me,
per month.
even I do a lot of.
The problem here is that we did one dissertation, putting a drain in a subtotal thyroid, putting a drain in a total thyroidectomy patient versus
Yes.
not putting a drain and putting a drain in hemithyroidectomy patient or not. It has been, our conclusion was that in a total thyroidectomy, you should put a drain. In a hemithyroidectomy, there is no need to put a drain. From point of the prolonged voice change, we have observed, particularly when we did not put a drain.
Yes, sir. Again, there are difference of opinion regarding that.
That's fine. That's okay. That's okay.
That's why. That is why I said whatever you practice as you mention in exam.
Sir, what do you do? You usually put a drain, Hitesh, sir?
Yes, sir. I always put a drain. There
Even
are
I
some
put.
different but there are
even
some
I
different
always put.
philosophies that I can discuss with you only on one-to-one, not here.
Yeah,
Yes,
I
I
can
agree.
understand. This is just for because we are giving broad spectrum to residents.
Yes,
so
sir.
nothing, because remember, there are always more than one answer. There are no fixed answer
Yes,
to each
yes.
and every question. Understand
So
this
what
point.
will
More than
in,
one thing can be
even in
right.
laparoscopic cholecystectomy, after being such a senior post, being on, even if I do, I put it. There is no harm in putting a tube through the same incision.
Absolutely.
You can remove it after 24 hours.
Yes.
And I always tell my students, never become senior.
Very good, sir.
Just by your
It's a
number
very
of
good
surgeries,
thing.
never become senior.
Yeah.
I still aspirate the bladder before opening urinary bladder.
Good, sir. So,
Okay.
Nikunj, you have put the drain. Which drain you use?
Sir, I use a Romovec negative suction drain.
Which number?
Sir, 14 number.
Okay. And then how you close the strap muscles?
By using simple interrupted suture, vicryl suture, sir. 20.
Okay. So you have closed the strap muscles. What next? Platysma?
Sir, platysma, yes, sir. Close in a simple interrupted inverting with inverting
So
knot.
before closing the platysma, what will you do?
Very important question that you have forgotten to answer that before closure. When I asked for closure,
Yes, sir. Hemostasis, I would check for the hemostasis.
ये तो drain आएगी ये सिवाय. Sister Saronte बुलाओ.
Yes, sir. To remove the shoulder blade support which is given to shoulder blades.
Yes. And how to
If
check
there
for
is-
hemostasis?
Yes, if there is a bleeding after ligating or securing inferior thyroid artery near the recurrent laryngeal, how will you control?
Sir, by using bipolar cautery.
First
identify the point. Exactly the point identification.
Yes, first press it for 5 minutes. Right?
Yes,
Then
sir.
identify. And if possible, if you can hold it with forceps, better to ligate it rather than using any sort of gadget. Any current will deviate to some extent. If it is away from now, and if you can identify a lumen, many times you can identify a lumen, and that is why role of loops come. I'm not using, but if you are using loops, it will be very helpful. Magnification. If you can identify, pick up, sparing the important structures, better to ligate it with finer sutures.
So the first thing is to put in a pack. If it
Yes,
is controlled,
I
well
told
and
it.
good.
5 minutes. 5
Yeah.
minutes. You wait. I already told it, Apurva, that you wait
Yes,
for
sir.
5
I'm
minutes
just
after putting
emphasizing.
the.
I'm just emphasizing
Yes,
that
it is
whatever
mandatory.
gadgets you have, whether you have a
Yes.
harmonic or a bipolar, always. Yes, sir.
Nikunj, sir has specifically asked about platysma. Why?
Sir, because sir, closure of platysma gives a good supple scar, so it is mandatory to
Why
close the
it
platysma.
will give good scar?
Why platysma? What is the problem in the midline you see? In the middle part.
There is no platysma in middle
No
part.
platysma in the mid
Yes,
part.
sir.
No platysma. You have to just approximate the fascia.
Yes, sir.
Okay. So
What is so specific about platysma in body? What is so specific about platysma in body?
Sir, platysma is the only subcutaneous muscle present.
No, there is another
No.
muscle.
Something else.
Don't put adjective. There is another subcutaneous muscle in body. Tell me, as a general surgeon, you must have done so much of surgeries in that part.
Surgeries. Yes, very
In half of the population, in half of the population of world.
Sir, in case of
No, in circumcision, you don't see any muscle.
yes, sir.
Nearby.
I don't know, sir.
Dartos.
Dartos, yes, sir.
Actually, there are so many subcutaneous face muscle. All facial muscles are subcutaneous
Eyelids,
muscle. That is not
eyelids
the
and
point.
others.
But
This comes in our.
the point is why you need to separately suture platysma.
Sir, it gives a contour to the neck.
Time-tested thing that you cut platysma slightly higher than the skin incision. Because otherwise the platysma is subcutaneous muscle may stick to the scar and give the puckered scar. That is the one reason that platysma should be separately sutured and even cut not at the same level. That is being recommended.
Yes. Another reason, another thing in incision, even if you have a lower swelling, you don't put much lower incision. Otherwise, the upper skin will be hanging over the lower flat. So you keep at least 2.5 centimeter above because of lymphatic obstruction.
Yes.
So you put it at least 2.5 centimeter above suprasternal notch. This is given in anatomy part of mastery.
One important question: what will you tell anesthetist after removal of thyroid and before doing the closure? What will you tell your anesthetist? After removal of thyroid has been removed, thyroid nikal gaya, and you have to do the closure. Now, at this certain point, what will you tell your anesthetist?
So to check for blood pressure, sir.
And what else? What anesthetist will do that will help you? At this certain point only, after removal of thyroid and before closure, what anesthetist will do? They will give a positive pressure. The positive pressure will inflate the chest. That will in return inflate the internal jugular veins, and that will cause any bleeding points to open. It is known as Valsalva maneuver. It is mandatory to do a Valsalva maneuver before closure. If any vein does not open in the Valsalva maneuver, it means it will not also open after the patient is coughing up in the wards.
Yes. And on left side, if it is a large swelling, you have to look for that. If it is a large swelling in lower part, you have to look for duct also, thoracic.
Thoracic duct.
Yes.
Very rare, but if you damage it once, you will have it in life.
Yeah. Right, sir. Anything?
Okay. So I think that's all.
Yes, sir. Very.
So sir, we have discussed theory, but for a student point of view, important point is a complication.
Yeah, sorry.
Because that is the one point I would like to discuss. What are the common complications after total thyroidectomy? Because this is a very important point, you are going to face them.
Sir, there can be hemorrhage.
Okay.
Sir, there can be hypoparathyroidism. there can be injury to the recurrent laryngeal as well as recurrent external branch of laryngeal.
Don't start like UG. Nikunj,
Yes, sir.
you have to answer like PG
If,
student. How do
sir,
you classify
immediate
any
complication.
complication?
Yes, sir. Immediate complication like hemorrhage, intermediate
So-
complication.
Okay. So
Intermediate.
hemorrhage, what do you do it? What are the causes and what do you do?
Sir, in case of hemorrhage, I would open the stitches along with the stitches which has closed the strap muscles to let out the hematoma. And
So where do you open the stitches?
All the skin
Where-
sutures,
No,
platysmas.
no, where in the OT or in the ward?
No, sir, immediately in ward, sir. Later on, sir, patient can be taken in OT and explore for the bleeding site, sir.
Routinely, especially after subtotal, we used to have. I think I don't know. Sahib used to have, but after total thyroidectomy, it
Yes.
is less likely.
Yes, there was a more of a bleeding in subtotal thyroidectomy. We have
Yeah.
observed because when we were residents and early, we used to see lot of bleeding because the raw area of thyroid used to bleed and large part of thyroid was usually left behind. Specifically in a Graves' disease, there was lot of bleeding.
Yes, sir.
Nowadays, we rarely see that kind of scenario because I still remember 2 times I had rushed the patient in OT after opening the suture. That's fine. Hemorrhage and that is all right. What do you mean by hypoparathyroidism? Because I would really like to discuss that.
Sir, hypoparathyroidism is a clinical features of low parathyroid hormone, which is manifested by the signs of tingling, numbness, perioral numbness, with sometimes severe form can be as a tetany, sir.
What is the reason?
Sir, it can be temporary hypoparathyroidism or it can be permanent hypoparathyroidism. Temporary usually manifest into 2 to 5 days because of vascular insult to the vessel supplying parathyroid, or permanent due to removal of all 4 parathyroid glands in case of total thyroidectomy.
Sir, would you like to ask anything about this?
I think that's all, sir.
That's all. Okay.
Dr. Sahib?
Yes, I want to ask one thing. Suppose you remove the parathyroid glands and if you know in the specimen after thyroidectomy that parathyroid glands are out, what will you do?
Sir, I would like to sir reposition it in a right sternocleidomastoid, sir.
Okay,
Good,
now
it is
there are
not-
certain confusion. Somebody says that instead of that sternomastoid, you put it on the forearm on like that. So what
No,
is the
sir.
opinion of Dr.
Sir,
Agrawal?
best thing is sternocleidomastoid muscle only. Just take the parathyroid tissue from the specimen and just mince it in very small pieces, less than 1 millimeter pieces, and insert into the sternocleidomastoid muscle. That is the best thing.
Sir, what you are asking is that in arm, usually implantation is required when we are doing for secondary hyperparathyroidism.
Hyperthyroid.
When remove 3.5 parathyroid, it is preferable in arm. So it is easy to remove it if required. But in case of thyroid surgery, it is implanted in sternocleidomastoid.
Okay, then
And you
what
can
will
take
it?
a, when you implant in the forearm or arm, you also take a suture with the protein, so identification becomes easier. This is theory. I have never done that.
Right,
I have
right.
implanted 2 cases but not removed them, so I don't know.
Okay,
That's
now how will you do the follow-up of the patient? When you have done thyroidectomy, what will be the post-operative long-term treatment or anything?
Sir,
What's the
patient
patient
will
operated for non-toxic multinodular goiter, total thyroidectomy done?
So I would supplement. I would give thyroxine supplements to the patient, 100 milligram.
When
OD.
will you start? When will you start?
Sir, I would start on post-operative day 5.
Why 5? Why 5? Why not 1?
Why
Why
5?
not
Why
10?
not 7? Why 5? Why
Sir,
not 7? And why not day 1?
Sir, because of half-life of thyroid hormone T4 is 7 days. Circulating thyroid hormone will be sufficient
That is 1.
for.
That is 1. That is 1. But why not day 1? You can give it on day 1. What is the harm?
Sir, if I start thyroid hormone supplementation, it will cause suppression of TSH.
Nothing. You can give it on day 1 easily because the patient was
You can give it,
euthyroid.
but if
So
you
you
are
can give it
suspecting
as well.
malignancy, and if you want isotope scan to be done, and if it is possible to get the date in short time, otherwise
Yes, sir.
there is no point, because usually we get appointment after 3-4 months. right?
Yes, sir.
So these are all practical questions. You might not know. It's fine. Well done.
What is the reason why you want to give thyroxine postoperatively?
So because total thyroidectomy.
So apart from replacement, why do you want to give thyroid?
Replacement is okay, but any other
Yes, sir.
concept for giving that? You may
Sir,
do partial thyroidectomy, suppose, or subtotal. Then you would like to give?
sir, thyroxine supplement is thought to be decrease the TSH level.
What you
Yes.
want to decrease is the TSH, or there is some other concept for giving that?
But a such question is very specific. He has done subtotal thyroidectomy, and after subtotal thyroidectomy, we do the subtotal thyroidectomy just in thinking that thyroxine may not be required. Then why you are giving thyroxine now?
One
If it is a
important word should come. To do that,
It prevents the recurrence of thyroid nodules, sir.
why it prevent the recurrence? Again, the same question.
Because
Answer is the same. What you want to do to prevent the development of multinodular goiter?
to decrease the TSH level,
Only to decrease or to something else?
He
fluctuation.
doesn't know. Please answer.
Fluctuation.
Stabilization, persistent stabilization, no? So that fluctuation doesn't occur, and it is the fluctuating level which is likely to be the cause of development of the multinodular goiter.
How much TSH will you keep by giving thyroid supplement? If you want it in a suppression dose, what is the thyroid TSH level you will like to monitor?
Lower limit of normal range, around 0.5, sir.
No, but
Okay,
less
fine.
than 0.3.
Less than 0.3.
If you want to suppress, then it has to be lower than normal range.
Yes.
Okay. Apurva, sir,
Yes.
any question anybody would like to ask? Because we can go on discussing, but it's already over. Everybody's tired.
Nikunj, you can ask any question. You can ask any question to any of us.
Any
If
students?
you have
Yeah,
any
any
query.
students have any
Suppose
question?
you have done the subtotal thyroidectomy and the report
sir.
comes, it is a case of follicular carcinoma, histopathology. You were
Yes,
not
sir.
knowing that it is malignancy. Then what will you do?
Sir, I would like to do completion thyroidectomy along with the central neck dissection, and if required, sir, lateral neck dissection also. sir.
बेटा सर ने बोला है follicular carcinoma.
Follicular word is used.
Follicular में lymph node metastasis नहीं होती है.
Follicular.
समझो
Yes,
बात
sir.
को.
This same question I asked him in round. His answer was same. I told him I have used word follicular. He is repeating the same mistake.
Nikunj, you should have said,
Am I right, Nikunj?
Yes, sir.
preferably, you should have said, preferably, I will avoid subtotal thyroidectomy.
That is
I will
fine.
always
That's why
like to
nobody
do
does subtotal nowadays.
Frozen section, and nowadays we have frozen section
Sir,
facilities
it has-
available.
Choksi, sir,
it has
we
no
will
role.
keep
has no
it for
role.
a next time. We are going to discuss malignancy.
Yes.
There will be
I
a lot of
think we
discussion.
toxic question.
Hemi
Frozen
versus
section
total.
has-
If you have done hemi, what will happen on that? So we'll
Sure.
just
And
leave it like that.
frozen has
Okay.
no significant role as far as the literature and academics are concerned. Am I right, Sir Ritesh, sir?
Sir, if we are doing hemithyroidectomy, frozen section is mandatory. If we are doing a total thyroidectomy, frozen section is not required unless we are seeing any lymph nodes which needed frozen section. That's all.
Okay.
Yes, I agree.
Okay, so shall we call it a day, sir?
Yes.
Yeah.
Thank you very
Yes,
much.
right.
Thank
Nikunj,
you.
you did
Thank
well.
you.
Sir.
Yeah.
Thanks a lot, Pankaj sir, Dilip sir, and Hitesh sir. Thank you so much. Thank you,
Thank you.
Nikunj.
Thank you,
Sir, have a nice day,
Very
sir.
nice.
Thank you, everyone.
Thank you.
Thank you.
Good day, sir.
Good day.